Sir, you can start the session.
Yeah. So good evening to all of you. As usual, I will start with a short case first. Can you see my screen?
Yes, sir, perfectly.
Okay. Now, it's a short case. This is given by Dr. Joy. Now, it's a short case. What are the ocular findings in this patient who came with ataxia? Take your time, see the video. Looking straight, looking to the left side. To the right. Right side. Look to the left. Right. So, what are the findings in this patient? I'll show the video once again if necessary. You want me to see the video once again?
Yes, sir.
Okay, because it's a difficult video, I think you have to see once again. Okay. Okay, look to the left side. To the right side. Looking up. Again, looking to the right side, close up view of the left eye. Look at the eyelid also. Okay. What are the findings in this patient? I think I'll show it in once again in slow motion. Looking to the right side. Looking to the left side. Looking straight ahead. Okay. So what are the findings in this patient? Is that difficult? On looking to the left side, she has got a coarse horizontal nystagmus. On looking to the right side, again a horizontal nystagmus, which is again beating to the point of fixation, but with a lesser amplitude. So looking to the left side, fast compound to the left side and a coarser amplitude. Looking to the right side, fast compound to the right side with lesser amplitude. So what could this is present on both eyes? So what could it suggest?
Bruns nystagmus, sir.
Yeah, this is a typical Bruns nystagmus. May I ask you one question? Why can't be left cerebellar lesion per se, only flocculus lesion on the left side? A unilateral cerebellar lesion also can produce case of nystagmus, and the amplitude will be more on looking to the side of lesion. Correct? In cerebellar lesion, flocculus lesion, that also can produce case of nystagmus, more amplitude left side. But as you said correctly, this also could go with a Bruns nystagmus. In Bruns nystagmus, the ipsilateral large amplitude nystagmus due to the cerebellar component. The conlateral fast component nystagmus is due to the vestibular component. That's a Bruns nystagmus is a combination of cerebellar affection and vestibular labyrinthine nerve affection. But frankly speaking, to be absolutely certain to call it as a Bruns nystagmus, the right side nystagmus should be vestibular. Here we are not sure it is a part of the cerebellar involvement or not. So ideally, the contractile nystagmus should be fine, fast frequency nystagmus. That again is not enough. If you got a primary position nystagmus or looking straight ahead, beating to the right side, that pakka tell you it is a Bruns nystagmus. That means it's a combination of cerebellar nystagmus and the vestibular nystagmus. Why? Because in the primary position, cerebellar lesion will not produce a nystagmus. That means in the gaze-evoked nystagmus due to cerebellar lesion will not produce a nystagmus or movement in the primary position. Okay. So it looks like a Bruns nystagmus. And anything else in this? Yeah, any doubt, please?
That can be a Bruns nystagmus. I mean, that can be a rebound nystagmus can happen in the primary position, no?
No, here in the rebound nystagmus should be beating to the opposite side.
Yeah, it's on looking to the left, it's beating to the left, and the primary position is beating to the right.
No, primary beating to the left. I'll show you that finding. It's actually not beating to the left side, it is beating up. I'll show that finding later on. Okay. Yeah, I'll show the video once again. If you look at it carefully, it appears as if it is beating to the right, or when you have to bring it to the primary position. This is beating to the right side. It's a slow nystagmus, little less amplitude nystagmus. It's got large amplitude nystagmus. All goes with the Bruns agreed. Now look at the primary position now. See, it is not beating to the, if it is vestibular, it should be beating to the right side. It's not beating to the right side. If it all beating to the left, but actually it is beating up. Look at the eyelid. Look at the eyelid position. It is beating up. It's actually upbeat nystagmus which is seen there.
So in a vestibular nystagmus, if it's beating to the right on looking to the right, can this be still vestibular when it is beating up in primary position?
No, it cannot be. So this upbeat nystagmus is not part of the Bruns nystagmus. I'll come to that later on. Okay. But otherwise, it can go with the Bruns nystagmus because the right-sided nystagmus have got a lower amplitude. Left side will be larger.
You said you take this as a vestibular nystagmus, which is beating the right side because in the primary position she has a nystagmus which happen in cerebellar. You said
that will not happen in cerebellar, but can occur in vestibular. In Bruns nystagmus, it's a combination of cerebellar plus vestibular. Okay. So when the vestibular system is affected, the labyrinth nerve is affected on the left side, you get a fast beating nystagmus in the primary position to the right, as well as looking to the right side. Here, the nystagmus which appears in the primary position is not beating to the right side. That is why I said it is not actually a vestibular component nystagmus in the primary position.
Initially you said because it's there in the primary position, it's more suggestive of vestibular. That's what I thought. That's what
but the direction is different. What you said is correct, but direction is different. Direction is different. Suppose left labyrinthine nerve is affected, you get a fast beating nystagmus to the right, not only right, primary position, even on looking to the right side, it should be beating to the right side. If it's a pure labyrinthine. Here, in fact, the primary, it appears not beating to the right, appears beating to the left, but actually I'll come to that later on.
If the patient had a primary position nystagmus just beating to the right, can we say it's a rebound nystagmus of the left beating cerebellar nystagmus?
Yeah, you can say, in fact, if you got a nystagmus is beating, you can say that. After subsidy, when you bring to the primary position, beating to the right side, you can say that. But here it is not beating to the right side, it is beating to the left side. You got the point?
Yeah, okay.
Even if it's a rebound, it should be beating to the right. Here it's beating to the left.
It is beating to the left or up?
Up. Actually, it's up. It appears looking to the left side, but it's not left. Because you look at the latter part of the video, if you look at the eyelid position, see, I'll come to that part here. So you get the eyelid alone. See, it's beating up. See this? It looks as if it is going down, but actually it's beating up. That is, the eyelid is going up. See that?
Yes, sir.
Okay. Now let us see. So this already mentioned. This point also I mentioned already. Vacant cerebellar nystagmus. Now go to the second part of the video. It's not enough. This video has got so many other findings. Now let us see this particular part. What do you think about it? On opening the eyelids, what will happen to the left eye? What do you find?
Lateral pulsion.
It's a lateral pulsion towards the left side. So lateral pulsion will not occur due to a pure labyrinthine nystagmus, not a pure vestibulocerebellar lesion also. So that indicates that what? There should be a lesion in the brainstem.
Yeah, brainstem.
In medulla, or it can be in the inferior cerebellar peduncle or superior cerebellar, depending upon where it is, where it's input from the inferior olivary nucleus to the vermis, or the output through the superior cerebellar peduncle. I think I'll forget about the explanation. It indicates that lesion has to be in the brainstem. Okay, so that indicates that this lateral pulsion indicates that the lesion is compressing the brainstem. Same thing I'll show it in slow motion. Look at the left eye. It's coming back. From the outward, there's already pulse towards left side and then coming back to the primary position. Okay, what you said is correct. Now, how do you explain this thing? Now, anything else in this patient? I will show this has already been mentioned before. Joy's question contained that. The way the same thing. And look at the eyelid is beating upward. In fact, there is another part of the video here that also showing upbeat nystagmus. I'm looking up. Okay. No, not convinced. I'll show the one. This is same thing. This is one. You see, the patients actually look up. See, you can see the upbeat nystagmus now. It's that. It is there. The upbeat nystagmus is there.
Yes, sir.
Yeah. So now the thing is that how do you explain the upbeat nystagmus in this patient? That upbeat nystagmus can occur due to medullary lesion, can occur due to brain midline pontine lesion, and also more commonly in the upper midbrain lesion. Okay. So here most likely due to the compression of the medulla. Here is the clue for the final diagnosis. Now, which side is affected here? Not to Joy, other people. Left side, obviously left side. Now, this is the clue in this patient for the etiology. It's got a facial palsy on the left side. It could be closure. Sorry, I'll come to that. I think the video got changed. In fact, that video it says in the latter, but I'll show that. Let me see, it is here. In fact, the video got changed. This is not the video I wanted to show. I wanted to show the facial palsy and all that is not here. In fact, the patient had left element facial palsy and hearing loss on the left side and numbness on the left side of the face. So all pointing to a left septal lesion. So this is the mass lesion. This is compressing not only the pons but also the medulla also, cerebellar medullary junction also. It's a fairly large CP mass lesion. That is why the patient is having an upbeat nystagmus as well as got a lateral pulsion on the left side. See the extent it is coming down, compressing not only the pons but also the medulla. So any questions in that patient? Any clarification you can please ask. Lateral pulsion I had seen many videos before also in lateral medullary syndrome. Okay, just to mention that in the medullary lesion can produce upbeat nystagmus due to the involvement of the nucleus of roller or nucleus intercalatus. Why the mechanism is like this. Normally the pathophysiology of upbeat nystagmus is because there is a tendency for the eyes to drift downward and there is a corrective component is upward. So any nystagmus is a pathological component, slow component. So in upbeat nystagmus, what happened? The pathology is that the eye somehow or other is pushed downward and the body corrects it correct it in the way that it makes a saccadic movement upward. So what happened? This is the pathway for the upward movement. This I mentioned before. That is connection of the superior vestibular nucleus to the upward moving muscles like superior rectus. When there is a lesion here, usually in the mental tract, usually these days bilateral, the eyes tend to move downward and there is a corrective fast component upward. That is a classical pathophysiology of nystagmus. But it is more to it. The superior vestibular nucleus here in the central part this is the pathway which I already mentioned, is driving the superior rectus upward by a tendency to push the eye upward. This superior vestibular nucleus is inhibited by the flocculus, and this flocculus is again inhibited by the medulla. So in floccular lesion, what will happen? This inhibition will be lost. So there will be much more moving upward, and then you get a downbeat nystagmus because there is an upward bias is increased. Eyes will tend to slowly go upward and then downward nystagmus. This flocculus is in turn inhibited by the medulla. So it will affect, it is as if the flocculus is, this inhibition is lost. That means the eye, this pathway is affected. The eyes tend to drift upward and fast component upward. Just to the opposite of flocculus. So flocculus lesion body don't be nystagmus. Since the flocculus is inhibited in the medulla and the inhibition is lost, you get an upbeat nystagmus. Okay. Any doubts? Okay, so here why the upbeat nystagmus most likely due to the involvement of the caudal medulla. This is the same thing which is shown here. When there is a lesion, the inhibition is lost, the flocculus is overactive, the flocculus produces excessive inhibition of the superior vestibular nucleus. That means the upward bias is inhibited, the eyes tend to go downward, and there is a fast component upward. Okay, shall I go to the next case?
Yes.
Okay. Yeah, right. This is a story of a 68-year-old hypertensive. This case I've seen 2 years back, 3 years back, given by Dr. Divya. Her complaint started 2 days back. While she was standing in the kitchen, she noticed numbness. In fact, I clarified it is not paresthesia, she said heaviness and numbness, along with the weakness of the right lower limb. That is what she said. She sat down and required the help to get up and walk. Since that time, she noticed that she is dragging her right foot. That is only complaint. No pain, no real paresthesia, heaviness and numbness, inability and dragging of the right lower. So this is the video of the patient. Findings are confined to the lower limb, upper limbs are normal. So I will show the lower. There is spasticity to the right lower limb and walking that I will show later. Hip flexion is normal. Knee extension is also normal bilaterally. Dorsiflexion is normal on the left side, weak on the right side. The AHL is weak on the right side. It is mildly weak on the right side. Dorsiflexion is normal. Plexopathy longus, sorry, plexopathy longus is also mildly weak. Eversion is mildly weak on the right side. Right knee jack is brisk. Bilaterally, in fact, bilaterally brisk more on the right side. And knee jack is normally elicited. Plantar was indefinite. Sensations normal. Equal. It's also. She said correctly. She said everything. There's all correct. She said correctly. No cortical sensory loss. She is able to say 6 correctly. No graphesthesia. She drags with the right limb with circumflexion on the right foot. So, an examination, power weakness of abertus, invertus, EHL, and plexopathy longus, all gate 4 plus, resolution was normal. Sparsity of right lower limb while walking. Detail both knee jacks were brisk, both ankle jacks normally elicited, plantar indefinite, sensory normal. SLR negative, and drags a right lower limb while walking. So, acute presentation, what is the likely diagnosis?
Cortical
Okay.
cluster or myelopathy above D12.
Which body on the spinal cord on one side, or is it a cortical, which is more likely in this patient?
More likely cortical, sir.
Yeah, more likely cortical lesion because she has no sensory findings. Suppose it had been a lesion on the cord on the left side, it is possible, definitely possible. We expect the spinothalamic tractors to be affected or postoperative to be affected on that side. So you expect a pain loss on the contralateral side or a postoperative loss on the same side. It's not there in this patient. It's really abrupt onset, acute onset of one lower limb weakness with dragging without any sensory, more likely paraplegic. That's the first possibility. Okay. Any other thoughts you will anyone like to keep? Agreed? So what investigation you want?
MRI, sir.
MRI brain.
brain.
Okay. Okay. It was done 24 hours later. So this is MRI brain. Diffusion. There is no area of diffusion restriction in the parasagittal area. So what do you like to do? Sometimes, in fact, maybe missed in the initial 24 hours. If repeated the MRI for one more day later, this is MRI done later, so 1 day later. I took a coronal cut this time because sometimes small input can be missed if you take an axial cut alone. So we did a coronal diffusion cut. Sorry. So that also will not change anything. Now, what do you like to do?
Spine.
Pardon?
Spine, dorsal spine.
Okay, dorsal spine. This is a dorsal spine. I will show the axial cut. Normal.
Cervical spine.
Cervical also. Okay, cervical spine was also normal. What to do now?
The nerve conduction could be an axonal form of GBS.
But it's a pyramidal spasticity, no? It's got a circumduction gait, dragging of the feet, stiff limb, wrist reflexes. So
Upper limb sensations normal, sir.
normal, upper limb perfectly normal. Upper limb no findings at all.
Review the scans again, sir. Dorsal.
Okay, review that. What you said is correct. So I took a thin cut at the D4 level itself. Now look very carefully now. So unless you have a strong suspicion, you have to ask the radiologist to do the thin cut again and concentrate on that thing. See, it's got a hyperintensity on the right side of the body. Can you see that? Arrow is pointing. Not only there, at this level, there is on the right side, there is hyperintensity. That can make little, the arrow is pointing to that area. So contrast was done. There is mild contrast enhancement which can be seen there on the right half compared to the left. That is a subtraction image. That is appearing black. Anything else you want? So there is a hyperintensity in the right side of the dorsal cord.
Diffusion weighted.
Very good, very good. Picket presentation. No? So this is the diffusion. In fact, it is merged because I enlarged it. That is why the resolution is appearing like that. Actually, it is. Now you can make it. See the diffusion restriction there on the right side. Some days you may not get very clearly, but here you could make it out very clearly on the right side. So what is the likely diagnosis in this patient?
Spinal cord infarction.
Spinal cord. But he is confined only to the perimeral tract. If it is artery involvement, if the artery which supplies the perimeral tract, the level should also involve the parenchymal tract as well.
Need not always, it depends on how the artery supplies.
Correct. That's exactly the answer. See, in ischemic myelopathy, it need not fit in with the classical territory, especially in the cord. Some is only contained with the perimeral tract, some is only posterior column. Sometimes posterior column is parathalamic form, that also is known. When you know, especially when there is fibrocartilage embolism, that may go into branches of the vessels. So if it is a perimeral tract, which vessel is likely to be involved in this patient? It is not whole antispinal artery. Then it should be bilateral. It is only unilateral. This is sulcocommissural artery. Now the spinal cord, the antispinal artery supplies the spinal cord through sulcocommissural arteries. It never produces a T bifurcation supply both sides. It always goes to one direction. One sulcocommissural artery goes to the left side, the other one goes to the right side. Like that, it supplies the spinal cord. So if that artery is affected, you can have only hemicord syndrome. Sometimes a partial brown circuit syndrome can occur because the perimeral tract on one side, the contralateral parathalamic may be lost because these two tracts comes under the purview of the supply of the spinal artery and the spinal artery, sulcocommissural artery. So here sometimes it may be only confined to the So re-examine the patient to find out any clue to suggest any this thing. I check the sensation. He said no difference anywhere.
ഇല്ലല്ല ഒരേപോലെയാണ് ഈ ഞാൻ വരയ്ക്കുന്നതും ഇത് ഒരേപോലെയാണോ? ഇല്ല, മുകളിലോട്ട് വരുന്നൊരു കൂടും അങ്ങനെയൊന്നും ഇല്ലല്ലോ. ഈ കുത്തുന്നതും ഇതും ഒരേപോലെയാണോ? ഇതും
So what could be the explanation? So what else you want now? But what caused the infarct? We know it's infarct. What caused the infarct?
Iotogram.
Iotogram must be done. So before that, you check the vertebral body to find out whether there is a lesion in the vertebral body. That will give an additional clue to tell that it is ischemia. So far, we are only indirect evidence because the diffusion restriction is there. Now, what do you look at? What do you find here?
Dissection.
It's got hematoma in the aorta. It's a mural thrombus. Look at mural thrombus in the aorta and with hemorrhage. There is any wall of the aorta.
Isn't that dissection?
There is a dissection.
She does not have abdominal pain.
That's a peculiarity. If you had a pain, it would have been easy to make a diagnosis. She should not have any pain at all. And she had a hematoma in the aortic wall. Still, that did not produce any pain. So that's the story of the patient. So whenever you got a monoplegia, if you don't find lesion in the parasagittal, that is the most common thing, as you already said. You also look elsewhere to find where you would search all over, whatever be the site which can produce monoplegia, you look at that site and concentrate on that site. Okay. Any questions? Right. Shall I go to the next case?
Yeah.
Today I
Yes, sir.
only got all. Yeah. Any questions? No. Yeah. So today only short cases, not long cases. Now this is another short case. This is a story of a 50-year-old lady. She was referred to the EMG lab to rule out CT, carpal tunnel syndrome, since she complained of numbness of the left hand. NCS the left hand showed left carpal tunnel syndrome. But on stimulating the right median nerve to find out whether there is a carpal tunnel syndrome on the right side also, which is often be the case, no potentials were picked up on the distal and proximal stimulation from the thenar muscle on the right side. However, she had no complaints pertaining to the right hand. This is the median motor. Wait, the sound is just 1 minute. I will say the sound is not.
നമുക്ക് ഇവിടെയാണ് ഇങ്ങനെ റെസ്പോൺസ് വരുന്നത്.
Just 1 minute. I'll increase the sound also. Some sound not coming.
അത് നമുക്ക് ഇവിടെയാണ് ഇങ്ങനെ റെസ്പോൺസ് വരുന്നത്.
See, there is no potential is coming out. So there is distal stimulation, proximal, there is no potential, but the fingers are flexing, thumb is not flexing.
അത് നമുക്ക് ഇവിടെയാണ് ഇങ്ങനെ റെസ്പോൺസ് വരുന്നത്.
Then check the median sensory. Median sensory potential is present. So what could be the problem in this? Sensory is there, median sensory.
Sir, anomalous median nerve, sir.
Anomalous
And
median nerve.
anterior interosseous nerve affection, sir.
If anti-interosseous is affected,
Martin-Gruber.
Martin-Gruber anastomosis.
anastomosis, okay, perfectly right. But you have to prove it now. How to prove it now?
You have to stimulate ulnar, sir. Ulnar.
So we stimulate the ulnar nerve, correct? So start to stimulate in the ulnar. Initially, this ulnar nerve, you get the ulnar nerve. Let's pick it from the ADM. There's a normal potential from the ulnar nerve. So ulnar nerve is K. This is a proximal ulnar nerve stimulation. This is ulnar snap. So ulnar nerve is normal. Now what will you do?
Pick up the ear to
You have
start.
to ADM. Instead of ADM, you have to keep it in APB, sir.
Yeah, correct. You have to keep the APB and then stimulate the ulnar nerve, correct? Okay. So techniques is stimulate. Instead of that, so in the palm to find out whether she could pick up from the palm stimulation. Did it pick from the palm? See, the thumb is contracting now. There you can get the potential. So that means that the input to the thenar is not coming from the median nerve. Somewhere else it is reaching. Ultimately, the distal part of the median nerve it is joining. You're still stimulating the median nerve in the distal part. Okay, but not proximal to the wrist or at the wrist. So some communication is reaching at that level. So it is reaching at the thenar level. Okay, now what will you do? That is what you already showed. Okay. Now what do you want to do now?
Stimulate distal ulnar.
Correct. Stimulate distal ulnar and pick up from the thenar. Okay, very good. So that is then we have to know how thenar is getting innervated if it is not in the proper median now. So pick up electrode in the APB and ulnar stimulation.
Median തന്നെ ulnar.
See, you get a good potential there. Proximal also stimulating good potential. So even in ulnar stimulation in the distal part as well as in the elbow, the thenar getting stimulated. So the thenar muscle is activated. And the distal palm it is stimulating, and also it is stimulating the thenar muscles. So where is the problem here? Where is anastomosis here? Why is reaching there? What does it indicate?
The distal
Sir, at the level of the
communication.
Yeah.
sir, at the level of the elbow,
Right.
you
It should be
stimulate the
above the
median
elbow. Yeah, because it should be above the elbow. Usually anastomosis in the forearm. Here it should be above the elbow. Then only you can
Yes, sir.
explain this. Yeah. So the median input to the thenar is reaching the crossing out to the ulnar nerve above elbow and descending all the way down. And in the palm recrosses and goes to the distal median nerve and supply the thenar muscle.
Median തന്നെ ulnar.
So then I picked up from the distal ulnar. Again, you can pick it out there. Same thing which I showed. Now the next question can be due to the, if you stimulated the ulnar nerve and picked up from the potential from the thenar. But could it be a volume contraction with the contraction of the adductor pollicis or underneath the thenar muscle? You understand what is a volume contraction? That means if you stimulate the ulnar nerve, see just below the
amplitude
thenar.
won't be that much. Amplitude won't be normal, no, sir. Median
No,
CMAPs won't be.
no, the problem is, see, you are putting an electrode on the thenar. Okay. So just underneath this adductor pollicis. Okay. So when you stimulate the adductor pollicis also, you get a potential. Because the
Then
electrode is over like
there
that.
should be an adduction of the thumb, no? It's not.
Very good. That should be adduction of thumb. But if it will difficult differentiate with little adduction and the flexion part. So let us see what Joy said is correct. Let us see the movement now.
Median തന്നെ ulnar.
Okay, it looks like a flexion only, not like adduction. So that is one, okay, right? What is the other point? To say that it
Other
is not
hand,
volume.
other hand, if you keep the
No,
electrode at the over.
No, that you can't, no, because somebody they need not necessarily with the equal amplitude morphology if you stimulate the opposite hand. You have to stimulate the same muscle to find out that. The other hand, the same muscle may be there, the amplitude configuration may be different. Okay. Now the thing is that look at the contraction of the thenar muscles on ulnar stimulation, just like what you got in the palmar stimulation. Okay, then that shows it is not an adductor pollicis. A pickup electrode from the AP stimulation here.
Median തന്നെ ulnar.
Now, next thing is what I wanted to do now is that with the hypothenar muscle getting innervation of the median also. So you now know that the median is supplying through the ulnar the thenar muscles. Now, is there a cross communication? Is the ulnar is supplying the thenar and the median is supplying the hypothenar? That's also possible, no? Then what will you do? The other way around. You put the electrode on the hypothenar and stimulate the median. So I did that also. There is no activation of hypothenar or medial stimulation. Again, stimulated proximal median, no potentials from the hypothenar. So the communication is from the median to ulnar, but not from ulnar to median. Okay. And similarly, distal per taken. That's what we already showed. So no potential picked up from the hypothenar or median nerve stimulation.
Then why is she having numbness?
Like she did not have any complaint on the right hand.
You said she had numbness, no?
Left
That is on the
hand.
left side. In fact, she came for the CTS study on the left hand. That's what CTS. Okay. But whenever you do a CTS study, we do the other side also. When
Yes,
she
sir.
when the technique stimulated to the right side, he did not pick up any potential. Okay. Next, I wanted to know any sensory fiber input to the median nerve from the ulnar nerve. The motor input is not there. Let us see sensory input is there or not. Isn't picked up? No sensory input. As an artifact. No sensory innervation contribution of the ulnar to the median sensory distribution. Now, what is the diagnosis is Martin-Gruber anastomosis. Now, how to prove that Martin-Gruber anastomosis? Now, where is the crossing occurring? Then what will you do now? Logically, it has to be above the elbow. But again, you have to prove that point.
So ultrasound of the median nerve. Sir.
That
Elbow
that is not,
at the level.
That you
MRI.
already proven, no, by conduction.
but we know we have proven the crossing, but we have not proven where exactly is crossing. And this is
We
already
do
posted.
an hinging
MRI of the
technique.
elbow, sir.
Hinging technique.
Correct. Okay, no, let you see, simulate, see. I'm stimulating proximally. That is a median nerve. Nothing happening. Okay. Then stimulated proximally now, a little more proximal part in the middle now. You got the potential. You got the point. I'm stimulating the median now. Distally now, nothing. Elbow, just elbow, at the elbow, nothing. Above the elbow, you got the potential. And this is the last one, is the potential stimulated by the palm. The fourth one. The third one, above the elbow, in the mid arm. The first two, wrist and the last elbow. That means the crossing is above the elbow, somewhere about the middle part. That is where this crossing is occurring. If you stimulate the median at that level, you could get the potential. Below that, no potential. That means at that level, it is communicating with the ulnar nerve. Now, see the morphology of the CMAP is same from the ulnar nerve and the proximal median nerve stimulation. See, for example, this is the CMAP from the thenar on ulnar stimulation, which we got initially. Okay. This is CMAP from the thenar proximal median nerve stimulation at the axilla. See the morphology exactly the same. See the morphology. This is from the ulnar stimulation, no? Distal part, we got the morphology. The same thing got the median nerve stimulation above at the mid and near the axilla. Same morphology. That tells you that, conclusively tells you that the median nerve fibers are crossing through the ulnar at that level, and then പിന്നെ വിളിക്കാം മീറ്റിംഗില്ല പിന്നെ വിളിക്കാം. Okay. Clear? Any doubts in that? It suggests that anastomosis and median to ulnar is occurring above the elbow, not the usual side below the elbow. Now, how can you make sure that you are not stimulating the other point? Suppose you stimulate the above elbow. You can theoretically stimulate both, and both nerves are close by. The median and ulnar together. It's very difficult to selectively stimulate one median or ulnar nerve if you stimulate in the arm. Then how will you do? What will you do? Look at the muscle
By
contraction when
recording the
stimulate.
ulnar hypothenar muscle.
No, we can look at the muscle contraction. So what we usually do, we all depend upon the electrophysiological results given by the electrophysiology. We never go into the lab and see the personally, but you should make it a habit, because suppose you're stimulating the ulnar nerve, you may find the thenar muscle is contracting. Ulnar may not, the hypothenar may not be contracting. By that, you can be sure that you are stimulating the median nerve or ulnar nerve, whatever it is. Okay. I get the point. See, suppose you are stimulating, two nerves are in the elbow. I am not sure which nerve I am to stimulate. But look at the muscle which is contracted. If it is the ulnar innervated muscle, it is ulnar nerve. If it is the median nerve innervated, it is a median nerve. That you can make sure that you are in the median nerve or not ulnar nerve.
But then there can be an anomalous connection and this can go wrong, no?
Right. Right. If you think that if you don't look at the correct muscle, you may think that in fact the ulnar still it is proximal to that only. Because the thenar got stimulated by the ulnar stimulation distally. Here, if it is here also, you can get that thing. But when you stimulate here, you get thenar is contracting. The other ulnar muscle is not contracting. Then only you can be sure about that. If it had been a connection above that thing, in addition to the thumb, you can also get stimulation and contraction of the ulnar innervated muscles. Everything now is very simple to find. Just is only 1 and 2 into 2. That's the thing. The simple logical conclusion. Okay, then there are various types of anastomosis with Martin-Gruber, depending upon the communicating branch. This is the commonest one in the forearm, median to ulnar. This is a communicating branch. Or the branch may come from the anti-introitious nerve, communicate to the ulnar. Sometimes it comes from the muscular branches, supplying the FTP, the Prostodigitorum profundus, that you can join with that thing. Or there can be communication median anti-introitious nerve two connection to the ulnar nerve, either from the median nerve, another from the anterior introitious nerve. That's also possible. Or from the muscular branches to the ulnar nerve. That's also possible. So then you can have combinations. So various type of combination can occur from depending upon where it is originating. The muscle innervate will also differ, and the pickup also should be different. But I think forget about all these things. Remember only this one. This is the commonest Martin-Gruber anastomosis. Now, anastomosis between median and ulnar can occur in forearm region. It is composed of crossing process of axons from the median to ulnar, which may produce changes in the innervation of the upper limb muscles. The anastomosis involves axons leaving either the main trunk of the median nerve or the anti-introitious nerve, crossing through the forearm to join the main trunk of the ulnar nerve, ultimately innervating the intrinsic hand muscles. So this is the commonest one. The median nerve supplying the motor branch as well as sensory branch. From the branch supplying the thenar may leave out here in the forearm, join the ulnar nerve and travel to the wrist, recross to the thenar muscle. And this is what we got initially stimulated here in the palm to got the potential. Here in this part, the first one. We did not get a stimulation from here. Here, since our patients, our communication is much above, here also we did not get stimulation, but we stimulated here, no potential. Okay, that is why the thenar and the palmar stimulation produce, we could pick up the potential here. Okay, any questions regarding Martin-Gruber?
Since the
Sir,
other
how to
side,
differentiate volume conduction, sir?
Yeah, volume conduction is that because suppose you're putting electrode in the thenar muscle, abductor pollicis brevis. Now there's another muscle below that. Okay, that is adductor pollicis. Suppose this you are putting on the thenar and the thenar muscle is wasted, no thenar muscle at all. The adductor pollicis is underneath. If you stimulate the ulnar, you may think that adductor pollicis is contracting. You may think the median nerve is activated. Abductor pollicis is activating because of the volume contraction. The electrode is not picking up from the potential from the abductor pollicis, is picking up from the adductor pollicis, which is just beneath the muscle. So you may spuriously think that it is from the thenar muscle. Actually, it is not a thenar muscle, from the muscle underneath.
How to confirm it, sir?
The confirmation is looking at the type of muscle contraction. One is adduction movement, the other is abduction movement.
Okay, sir. Thank you, sir.
Yeah.
Sir, the opposite side, the symptomatic side, did confirm mild carpal tunnel syndrome, entrapment. So,
Yeah.
on that side, there was no such, Martin-Gruber anastomosis.
No anastomosis at that point. That said, there is no Martin-Gruber.
It's only unilateral.
Yeah, it can be unilateral, some can be bilateral.
If this patient had carpal tunnel on the right side, how would the conduction look like?
Now, in this case, carpal tunnel, there won't be a carpal tunnel because the median is not passing through the carpal tunnel. So you won't have any carpal tunnel syndrome.
But sensory, you said.
Sensory potential you can take. Yeah. Sensory potential you can take. Motor part you cannot take. Correct. Sensory was normal here. That can tell you that most likely it's not a carpal tunnel syndrome. You can't rely on the motor, but you can rely on the sensory. But you say this correct, Joy. Okay. Now, there are various other types of anastomose. This is important because sometimes you may come across one muscle may be extra innervated, you get confused whether it's two nerves are affected, canius might be a single nerve. So this problem will come. So it's better to know these other anastomoses. One is a Martin-Gruber, which you already said. Second is called Marinaki anastomosis. Second is Ricci-Cagno anastomosis and Barrettini anastomosis. I'll tell you each of this one. Most of the connections, this is the Martin-Gruber, which I already told you. Most of these connections cross from the median nerve to ulnar nerve and are bilateral in 10 to 40% of the cases. So here it goes from the median to ulnar, as you can see here. That is the commonest one. Sometimes the reverse can occur when the anastomotic branch originates proximally in the ulnar nerve and unites distally in the median nerve, is simply called anastomosis of ulnar median type, or Martin-Gruber reverse anastomosis, or Marinaki anastomosis. Here, it goes from the median ulnar to median. Instead of median to ulnar, goes from ulnar to median, or reverse Martin-Gruber. Okay. In that case, what will happen when you stimulate the ulnar nerve? You get the median nerve innervated muscle will contract. Then there's a Ricci-Cagno anastomosis occurs in palm because of the recurrent branch in the median nerve and the deep branch of ulnar nerve. So this I also seen one case where in addition to the thenar muscle, the patient adductor pollicis also was weak. Otherwise, thenar muscle, but the adductor pollicis was also weak. So I was got confused whether both are right, because you got a Foreman sign, it's got classical carpal tunnel, but Foreman sign was positive. I was unable to explain why it is occurring. This you can explain this Ricci-Cagno anastomosis, where the median branch is also supplying connecting with the deep branch of ulnar nerve, which supplies the adductor pollicis. So this is the Ricci-Cagno, where it from the ulnar nerve, it supplies the median nerve.
That you have shown before once.
One case I just shown before, correct. Joy, you've got a fantastic memory. I myself have forgotten. You remember that. Fourth is a Barrettini anastomosis. That is communicating branch between the common digital nerves that arise on the ulnar and median nerves in the palmar surface called Barrettini. That means the digital branch. So what will happen means, so instead of the 3.5 fingers, sometimes you get 4 fingers, or it may be less than, or whole palm may be supplied by the sensor. That also you have to keep in mind. But this is a rare type of anastomosis. There is a connection from the ulnar to the median. Digital supply. So when you can, instead of ulnar involvement, can sometimes produce not 1.5 fingers, can produce 3 finger involvement. Sensory loss. So naturally we think away from ulnar, right? We think in terms of a radiculopathy or a C7, the C8 radiculopathy thing, because middle finger is also affected. So rarely this possibility can occur if it does not fit in with other possibilities. So shall I stop here? Any questions in that case?
Sir, for what complaint the patient was referred, sir? Do they get a carpal tunnel, sir, in these type of anastomosis, sir?
No, in this type of, they are asymptomatic, in fact. But electrophysiologically, when you stimulate, you find these problems. Get confused as to why this is occurring. This patient had no complaint at all. Functionally, they are otherwise okay, because instead of one nerve, the other nerve is supplying that sound.
The first patient with Martin-Gruber, he was referred as CTS, sir. What was the complaint?
The CT numbers of the left hand. That is a complaint by which the patient came to me. He had numbness. So I wrote a usual thing, CTS protocol. CTS protocol means usually both hands. So he did the left hand, that showed a carpal tunnel. So he did the right side, he did not pick up any potential. That's why he called me. So I'm not picking any potential in the median now.
Okay, sir. Thank you.
Okay.
So anomalous
So-
anastomosis will not affect the sensory part, sir, of the median nerve?
No, they can. The last communication can affect the sensory, but the digital branch may supply may crossover and supply the other areas. Ulnar nerve area may be approached.
Proximally it will not affect us.
Proximally, I do not know. Only these things I know.
Yes, sir. Thank you, sir.
Theoretically possible, I do not know. Okay, shall we stop here?
Yes, sir.
15 more minutes.
Okay.
Yes,
Yeah.
one more case.
One more case. Okay. One more case. Let me see if it's a short case. No, this case, since the time is not there, so this case, which I shown earlier, the follow-up, that's very interesting to know about this particular case. This is a story of a 37-year-old male. He was admitted in de-addiction center 1 month back, and there he developed severe agitated delirium and had to be restrained for 3-4 days with arms tied to the coat. This I presented, say, nearly 8 or 9 months back. When the patient improved from the altered sensorium, he noticed severe weakness and numbness of his left upper. This is the video of the patient. ഈ കൈ ഇങ്ങനെ പിടിക്കണം, പിടിച്ച് നിർത്തണമേ. അതേ ഈ കൈ ഇങ്ങനെ പിടിച്ച് നിർത്താൻ നോക്കണം, നിർത്തിക്കണം. മാക്സിമം, വെരി ഗുഡ്, വെരി ഗുഡ്. അതേപോലെ ഇങ്ങനെ പിടിച്ചോ, വിടരുത്. അതെ, മാക്സിമം ഇത് പിടിക്കണം. ഏതൊക്കെ ഞരമ്പെന്ന് കണ്ടുപിടിക്കാൻ വേണ്ടിയിട്ടാണ് ആത്തോട്ട് പിടിച്ച് നിർത്തണം. ഈ biceps is 0 power. Deltoid is okay. That's on the normal side. Brachioradius is severely weak. Here gravity is also not there. Triceps is normal on the right side. Left triceps is grossly weak. The biceps brachial triceps is weak. Wrist extension is weak. 0 power of the dorsiflexion. No, 0 power of the finger. Lower limb, I think they'll skip their finding. There's normal lower limb motor examination. മുകളിലോട്ട് പിടിക്കേ, ഇതിലും പിടിച്ചേ മതി വിട്ടോ. All reflexes are absent on the left side.
ഇതറിയാമല്ലോ.
The sensation.
ഈ കുത്തിന് വേദന അറിയാതാവുമ്പോ പറയണം.
There is not feeling sensation at all.
ഇനി
Lateral part of the arm is normal.
ഈ മരപ്പ്
Not
മാറി
feeling anything.
നോർമൽ ആവുമ്പോ പറയണം. നോർമൽ
So in the medial part and lateral part of the arm is able to feel. That's the area is up to that level. No vibration. But deltoid part is okay.
അങ്ങോട്ട് പിടിക്കണം. സംഭവിക്കില്ലേ?
External rotation is also good power. Radially good power. Internal rotation also good.
എന്റെ കയ്യിലിട്ട് തള്ള.
That will be difficult to say because he cannot keep his hand extended because severe triceps weakness. So no Horner syndrome, mild wasting of the biceps, triceps and forearm muscles. Scale to 0 to 1 power of all muscles of the left upper limb except left deltoid, external rotators. Internal rotators were only mildly weak. DTR all absent the left upper limb, sensation, impaired sensation in the forearm, hand below the elbow. It was impaired in the lower part of the lateral arm. No sensory loss in the upper lateral or medial aspect of the left arm. This is the area of the sensory loss he had. So where is the localization? Is it pan-plexopathy? Is it C5 to D1 radiculopathy or intrinsic cord lesion?
Pan-plexopathy.
Pan-plexopathy. Why not radiculopathy?
Because deltoid and the others.
Right, correct. So, but even plexopathy you can't explain, no? Suppose plexopathy, see if the upper trunk is affected, in the biceps also 0 power.
Depends on which all fibers are involved.
Yeah, correct. Yeah, this type of patchy involvement we have discussed many times. Brachial plexopathy or neurology, we can't call it brachial plexopathy. Better to call neurologic hematrophy. That may not respect a trunk or a root distribution. May only some of the muscles alone may be affected. Some may be affected. Some alone may be can be spared also. Here it is curious. No, biceps is 0 power. At the same time, the deltoid and the intraspinatus separate with the same root and the same trunk is spared. Okay, so it means only part of the trunk is affected, or we can say better take multiple nerves are affected. Musculocutaneous is affected at the same time the axillary and the suprascapular nerves are spared. Okay, so that means those were a multiple nerve pattern. And that is a pattern which takes plexopathies, brachial plexopathies or a neurologic hematrophy. That's an important clue. So what investigation you want? This already mentioned here. Theoretically, you can say rootlets also affected could be possible because a root is having multiple rootlets. Some of the rootlets is submerged. You can get such a patchy involvement. That's already if it can't be at the level of the trunk because if upper trunk is affected, how can it spare the infradeltoid? The cord of the brachial press also is not possible. Affected the lateral cord, medial cord, post cord could be affected. That can be explained. So what investigation you need?
Conduction.
No connection.
Conduction. Okay, nerve conduction. This is 10 days after the insult. This is same cell value. See, left median APV potential is good, not mildly decreased, 3.4, ulnar 8.3, on the, so 5.2, F's point not stimulated. Other side is right. Left radial 7.3, good potential, distally, proximally not picked up. Axillary, again, axillary also affected, even not fully, 3.7, but power is good. Muscular cutaneous again, may not pick up, potentially pick from Deb's point. FA, median ulnar not obtained. So where is the site of lesion?
Distant to Erb's point.
Yeah, that's a conduction block. You have to say conduction block because the CMAP amplitude is not decreased in most of them. See, we grade 0 power. It's got a grade 0 power, but the amplitude is picked up. That means it cannot be an axonopathy. It has to be a demyelinating block, and that too proximal to the, because Erb's point there is a block. That means in the most proximal part of the brachial plexus. And see the sensory is normal. So that may confuse you with the radiculopathy. Why sensory potentials are normal?
It's only 10 days.
It's more than 10 days. Still, there is same explanation. There is a block proximal. You are all stimulating the sensory nerve distal to the block, demyelinating block. So you get a normal potential. Always remember the Kimura's dictum. In a weak muscle, when you got a normal CMAP amplitude, there is a conduction block. Okay, because that only thing is block is proximal to your stimulating point. So lesion is in the brachial plexus here. So you get a peripheral that plexus lesion is not axon involvement, it's in a demyelinating lesion. You get a normal sensory potential all throughout.
No, but the answer to your question, why the sensor is not involved, is because it's only 10 days, no? It's not because of the conduction block.
Yeah, and what I'm telling that even if it is 2 weeks, even if it's 3 weeks, this can occur, applicable.
Sensory can be normal,
Because
it be normal.
Can be normal, yeah, because it's a demyelinating block. This is applicable only for axonal block. Demyelination even 3 months also, the it will not progress distally. Snap will be normal. That is when you get a Saturday night radial pressure pulse Saturday, this thing, or conperonal pressure pulse, even after 1 month, even snap is normal. Because that pathology happens to be a demyelinating lesion. The snap we are stimulating distal to the demyelinating. Power may be 0, but your snap will be normal. Sensory loss will be there, but snap will be normal.
Okay, sir.
That's the other point is that see the FA, where is FA? See the FA is not releasing the median ulnar at all on the left side. With amplitude is normal, still there is FA is not there. Why? There is a block proximally.
If it is somatosensory work potential.
Yeah, that will be affected. That will be affected. But that has to go through the proximal part. So anything which goes through the block, if also is affected, no? Because somatosensory for the sensory. If you got if the sensations are lost, if the snap is normal, you have to do SSCP to find out whether the loss is blocked. The block is proximal to your stimulating point. For that, SSCP is required. The lower limb you can do the H reflex. That is sensory. For motor, you can utilize the FA. The FA also you should remember that it's a partial block can have a normal FA latency. Suppose you say proximal roots are affected partially. See, out of 10 fibers in the nerve, or 2-3 fibers are left behind. That will produce a normal FA latency because that fiber may conduct normally. To differentiate that, you have to look for chronodispersion or FA persistence, otherwise again miss it. So because our usual laboratory, what we look only FA latency we look. We never go and check the chronodispersion or the persistence of the FA. Out of the 10 FAs, only 2 will be producing a response. And that will produce a normal latency. You can get a spurious value of a normal FA. But all other 8 things are gone. So always check your electrophysiological data. And are you following? Any doubts? Please clarify, please. Here there's a
Sir.
demyelinating. Yeah, please.
Sir, so sensory, even if you may not be having any symptoms and you may not get any signs also, but SNAP will be normal. I didn't get it. SNAP, patient can have symptoms, no? Sensory.
I can, yeah. I'll tell you one example. Suppose you have got a patient with the convolutional palsy, and he has got to say nearly 3 weeks now. Okay, but the pathology happened to be demyelination of an axon block. So what will happen when you do the suprapernal stimulation, you're stimulating distally only, not proximal to the fibula head. Okay, you're putting an electrode on the dorsum of the foot and stimulating distal to that. So even a normal snap will be there. Why? Because you are demyelinating the snap and proximal to that. The patient has sensory loss. Why sensory loss? Because the impulse is not going to the brain. Because the block happens to be proximal, but you are stimulating distal. On the contrary, if it is axonopathy, invariably snap will be lost because the nerves will degenerate on the site of axon lesion. In 10 to 11 days, the axons will go off. So invariably, snap will be diminished if it's axonopathy, if done after 10, 11 days. But demyelination need not. But in this particular patient also, it's the same thing I'm trying to say. See, this patient has got, the examination, remember that he has got loss of sensation. Whole hand is no sensation at all. But see what is happening? His semipyramiditude is normal. Why normal? Because the block, the sensory potentials are, the nerves in the distal part is all normal. Only the sensory input is not reaching the spinal cord because there is a block proximally either in the root or in the proximal part of the plexus. Even if it is not too big, that you understand because there is a block there.
Yes, understood.
That's a basic difference between the demyelinating lesion and axonal lesion. Okay, proximal conduction of the motor. No potential whether absorption. See, the FAV is absent in the ulnar nerve in the presence of normal CMAP amplitude. That again tell you that there is a block proximally. The FAV has to go to the proximal part of the nerve or the root. So more likely Plexopathy, cytovascular Plexopathy. This also I have already explained. So this after done again it's persisting. Then after a few days. So what will you, how do you, the other point is that initially posed a problem, whether it's a toothless avulsion, that can also produce a normal snap. The lesion happens to be proximal to the ganglion, again snap will be normal. But here there's not a problem because for the stimulation, it is block distal to that is there. There is a block there, that is definitely there. If it is not there, again the problem will come.
Yes, sir.
Okay.
In an element lesion, if the power is grade
Yeah.
C, can we get
Zero, yeah.
Can we get normal F response? FA? Element
If
lesion.
the power, suppose imagine you've got a zero power, zero power. You can have a normal CMI potential if the lesion happens to be a demyelinating block proximal to your stimulating power. Okay. You get a normal power, a normal potential. That is what the Kimura has said. You got a weak muscle, unless if it's not functional or human, weak muscle, you get a normal CMAP. That means it is a conduction.
Axonopathy grade
Not no, it's not axonopathy. Axonopathy after 7 days you can decrease CMAP amplitude, everything.
I'm asking you the FA. Grade 0 power, axonopathy.
Yeah, grade 0 power also. what will happen usually is axonopathy means the axons are lost. So invariably the amplitude will come down after 7 days. Prior to that, you can get pseudo conduction block. Then you get everything will be go. So amplitude will be nil. Same thing which I have already
Sir,
been telling this.
prognosis.
Yeah.
So
Yeah,
prognosis
tell
will be
me, please.
different, sir, for adjunct.
Yeah.
Prognosis
Absolutely.
for the demyelinating block.
Yeah, demyelinating is a prognosis, very good prognosis. The axons are not lost. Only the myelin sheath is lost. They invariably has got a good prognosis. Just like our ADP and AMAN. In ADP, it's a demyelinating block, they got good prognosis. On the other hand, is AMAN variety of the axonal type, not the nodopathy type, get a poor prognosis.
Here, there are chances that the patient gets some power in the left upper limb, sir, after a few weeks or months.
Okay, let us see what is happening to this patient. So these are, I'll skip that thing and in the interest of time. So I was given, a patient given IUMP for 5 days and followed after 3 weeks. Looks out. Triceps has been improved. Triceps has improved. See the power of the tricep is 0 initially. The ratio was 0. Now it's to 3 plus to 4 plus. He is able to flex the fingers. It was not at all possible initially 0. That's also a figure that has become come up. Western rotation is also improved. That is also an almost normal initially also. Reflexes continue to remain absent, but power has remarkably improved in 3 weeks' time. And second follow-up, all the power improved. So that is the advantage of having a conduction block like neurology chemistry with an axonal variety. It's able to feel all the sensations now.
Is brachial neuralgia more commonly axonal or demyelinating?
More commonly axonal. But when you get a demyelinating type like this, he is lucky. See, 3 weeks, 4 weeks, so it's all right. Came after 2 months, it's perfectly normal. That is why? Because it's got a conduction block and the demyelinating type. Almost totally except for the weakness, the left biceps, small muscles, hand and right infraspinatus. And repeat conduction, see the repeat conduction. The block has improved. Except the radial, the amplitude has come down. Otherwise, most of the things have ulnar nerve, everything has improved. Suprascapular nerve has also improved. But the proximal median, proximal is FF latency is not come back, but the ulnar it has come back. It's a previous and recent comparison. You can see the no response, it has come back again. Left ulnar also is come back again. No response, it is ulnar, no response initially, it has become 42. Okay, that's the story. Okay, any questions?
Sir, one doubt, sir. So
Yeah, please.
in some brachial amyotrophy, we get severe wasting also. So that it will
Right.
indicate axonopathy. So are we justified in
Obviously.
giving it methylprednisolone?
Now, what else see? Suppose if you happen to see the patient early in the course, you should definitely try methylprednisolone. But once the muscle is wasted, the chance of recovery is going to be poor. The wasting occurs after 2-3 weeks time. The patient comes late, then the recovery of is very poor. But still they improve over a period of time. I've seen people improving after 1 year
Yes, sir. Yes, sir.
because the time taken for the axon to regrow. Still it will be incomplete.
Okay. Okay,
This-
sir. Okay, sir. So it is axonal variety which gives severe wasting. So the there are some brachial amyotrophy which are. Okay,
Yeah,
sir.
demyelination will not produce wasting at all unless axon
Yes,
is
sir.
secondly affected. Because the parent is intact, the axon is intact. If axon is intact, the muscle will not go into wasting. Unless a demyelinated lesion produces secondary axonopathy, the muscle will not waste.
So that means 3 weeks into the illness, the patient is not develop any wasting, and you are feeling you have a demyelinating, you are well justified in
Very
giving
good prognosis.
misotension, even if patient
Even
is
otherwise,
diabetic or okay.
yeah, even if otherwise you should give. Even if it is
Okay,
likely to axonopathy, just try.
Yes, sir. Yes, sir. Okay, sir. Thank you, sir.
Okay. So shall we stop? Okay, any further questions? Okay, sir. Sorry. Am I audible to you?
Thank
Yes,
you,
sir. We
sir.
can stop.
Yes, sir.
Yeah. Thank you.
Sir.
Okay, good night. Good
Thank,
night.
thank you,
Okay,
sir.
good night.
Thank you, sir. Good night, sir.
Thank you, sir.
Good night.
Good night, sir.
Okay. Good night. Next week, same time, we'll meet.
Yes, sir. Thank you, sir.
Okay. Thank you.